Now we are going to do the objective assessment. So remember, as I said, the objective assessment comes after the subjective. In the subjective, you also get information from the patient. But suppose that he has already given us the information about him, about his age, this young man. So we are going to now to look at the posture. Number one, for a cervical patient, it's better to ask them to do it in sitting. So I'll be looking at the posture. Anteriorly, I will check posteriorly to look what are the posture if there is no kyphosis, and then I will check if there is any poking chin. So when I look at him, already I see that he has got a deformity, slight deformity at the thoracic and the poking chin. Usually, the normal posture should be this one. Can you just post this so that you see? When I draw a line here, it falls on the manubrium notch. But let him take the normal posture, his normal posture. So there is an anterior move. Just take the normal posture. Just take your posture. You see there is a move of the chin. So when you move, remember when I said the move of the chin of 2 centimeters, it adds more weight on the cervical, 5 kilograms on the cervical. When you add 2 millimeters, you add more weight on cervical. So after the posture, you need to check the movement. Usually you can check the sensation and see if it is okay. But I ask my patient to bend the head forward and ask if there is any pain, this flexion. And if there is no pain, I will add over pressure. Okay? And if it is pain, I note it. And I ask my patient to do extension, back. If there is no pain, I add over pressure. And back. I ask my patient to laterally flex there. If there is no pain, I add over pressure. And here, no pain, I add over pressure. It's always to stand in front of your patient to see the reaction if they are feeling pain. Because sometimes patients will tell you that I don't have pain. But when you do this, you will see the facial expression. When there is pain, always they react. Okay? And you ask the patient to rotate. That's rotation. If there is no pain, you add over pressure. I stabilize here and I rotate there. And then the same, I rotate there. Okay? These are movements. If they are okay, fine. So, then next, I will go to the myotomes, because I need to test C1, I need C2 to check if there's before I go to myotomes, I need to check the sensation. You can use this. I can C1, C2, C3, C4, C5, 6, 7 here, 8, and T1 in between. And here also is T1. So you check, these are for sensation. Sometimes patient may lose sensation. So you have to start with sensation. Everything we can guide you on the right diagnosis. Then I'm going to test the muscle now, the muscle strength from C1, C2, C2, C8. Now, I start with C1. C1 is you ask the patient, don't allow me to push you back. I push back and they resist. You push forward, that's C1. C2, I ask my patient, don't allow me to pull you forward. That's C2. C3, it's laterally. Okay. C4, it's lifting your shoulders up like this. And when like this, I push down. Always you compare both sides. Now, C5, like this. No, here. And don't allow me to move you back. That's C5. C6, don't allow me to biceps. You bend. I push, you bend. C7, don't allow me to move you up. You push down. C8, like this. I ask you to, don't allow me. And then T1, like this. Then you test one by one. Just resist. Don't allow me to do this, or this, or this. So that's what muscles. If it is okay, then you continue. So now, after this, you test the reflex. For biceps, I will take and I check. You have to do it. You see now. Can you see that he's moving? Yeah, it's good. Then on triceps, I'm here, and I test. Yes, it's good. Then you do both sides. You have to do both sides. So on this one, I'm here. I put my hand on the biceps, the insertion, and I use this. You can see that the fingers are moving. Okay, and relax here. Relax. I do here just for triceps. You see, triceps goes like so. It's normal. It's fine. You ask the patient to lie down because now I want to test. Now to do Neurodynamic test. Go down. For Neodynamic test, I will do one upper limb tension test. Hold here and depress the shoulder, go into abduction, into external rotation, and then you extend. Do you feel any pain? Any stretching pain? There's nothing. Nothing. When there is pain, sometimes you can release the pressure here and see. So what I'm testing if there is a compression at the level of the neck. When it is painful, it means the compression of the neck at this level. Then you can also do the other side. Yeah. Depression, abduction, external rotation, and then you extend with your wrist extension there, and you check. You see, for him, it's not a problem because, of course, he doesn't have any problem. Now, if it is like this, what the other thing you can do in this position, because always remember, don't always ask a patient, turn and turn. Do everything they can do in one position, then you finish. In this position, remember, even if it is a cervical spine, you can also check where the clavicothoracic joint. You check when the clavicle attached the scapula. You check if it's not painful. All this will give you an idea. You can even test the cervical from here, because when I'm here, down there, I'm on the vertebra, but it's better when you do it in prone. So I ask my patient to turn, and it's better to have a bed like this when the patient can put the head in between for a better assessment. So on this one, for cervical, remember, you always have to check also. If you've seen that has got kyphosis, then you can see the bulk of the muscles, and also the muscles at the level if they are not stiff. But you always start with this one. Palpation, you palpate the muscles to see if they are not tight, if they don't have trigger point in them, because when you palpate, they say that physios we can see with our hands, with our fingers. Our fingers have eyes. So you can palpate and feel where you can find trigger point. Trigger point has those nodules you find in the muscles, which are very painful sometimes, especially when the muscles are tight. But after the muscle, you check the muscles, if they are the structure of the muscles, then you go into the bones. C1, you go, I use my posterior anterior. C1, it goes this way, so I have to do it this one. As I go down, I have to change my angle. That's C1, and as the patient is not painful. Usually when they have headaches, they will feel pain here, C1, C2, and C3. They will feel pain. It will be sometimes more prominent when they have cervicogenic headaches. So if it is not painful, you go to C2, you go to C3, no pain, C4, C5. Remember, I said from C4 to C6, that way you usually find C pain. Then you continue to C6, C6, 7, then you go to T1, T2, then you can go down to the upper, because this is what we call the upper quarter. This upper quarter, you check it, you check it if they are not. After the central PA, it's always good to do also the unilateral PA on facet joint. Sometimes when you have one side, you will find the facet joint is painful. Then you have to check with your thumbs and you compare both sides. You ask your patient to check. You will feel usually when there is pain, you find there's a change in the vertebra. Because he doesn't have any problem, I don't feel it, but that's how you do, and you compare both sides. Then you also have to check the first rib here, in here. You go in, you check the first rib, because the first rib, it's attached on up here on the T1. And T1 is somehow part of the cervical. It continues, that's a continuation of the cervical. C1, then you check if it is not stiff. Then you check now if they have a trigger point. Usually it's always good to put this here to expose them. And you check where the attachment of the levator scapula, where on the scapula, if sometimes it's very tender when it is painful, it comes from C45 here, it goes to, touches to superior angle of the scapula. Sometimes it's painful. Like my patient here, I can see have a winged scapula, which means that his serratus anterior are weak. So that will be part of the treatment. We need to retrain this so it can get on the, so when it is like this, it causes the anterior muscles also, they become tight. So you will check all here if they are trigger point, and you do also on the other side. So now, that you find that there is a problem. Now I start now to explain some treatment that can be used. Usually, when demobilization, it's similar to all of them, unless it is very painful. When it is painful, you need to be careful. You need to start first of all treating this pain using tense or heat. Sometimes when it is still acute, you can also use cold. But otherwise, you do MOBS, mobilization for pain, which will be going to be grade 1 and grade 2. I'm not going to that. But the most important thing we need to understand here is to identify what is the real problem. Is the problem degenerative? Is the problem traumatic? As I was explaining there on the different conditions. Then once you get the right condition, then the treatment will depend on the condition you get. And then after that, it can be PS, it can be transverse, it can be traction. If you find that you have to do traction, and you need to do myofascial, of course, if you have trigger points. If you find that you have to do traction, you can ask the patient to lie on the supine. Lie on the spine. I'm just to go through the different treatment techniques that can be used. Yeah, relax on my hand, and then on this one, you can do traction in this position or in the sitting position when you use Mulligan technique. So when you use this Maitland, that's why you hold the head. It has been in neutral position. This one is there, supporting the head, and this one is on the occiput, and then you pull slowly. You ask the patient how they feel, take the breath in and out, and then you hold and you relax. Sometimes it is still painful. But let's say now that here you are just trying to there is a compression. You want to decompress the nerves. But remember, I said you need to work on deep neck flexors. That's number one you have to do for exercises. So you need to give, so I'm going to go through the, come up. Yeah. Yes. Before I go to the exercise you can prescribe to your patient, I want to show you how you can test the vertebrobasilar artery insufficiency. As we said, it has dizziness, diplopia, dysphagia, the 4Ds, nystagmus, and sometimes nausea. So, the patient in this position, they ask the patient to open the eyes to look at you. Nystagmus is that movement of the eyes, especially when the artery is compromised. So you hold the head like this, then you do rotation, full rotation. You ask the patient to keep the eyes open. You hold there for 10 seconds. You look if there is no nystagmus. If there is nothing, no dizziness, then you can bring it. You wait for 10 seconds. You ask the patient, no dizziness. You look at the eyes to see if there is no nystagmus. Then you turn. It's passive. And to full range. And then you check also for nystagmus and dizziness. If there is nothing, it means it's not vertebral basilar artery insufficiency.